So now we move ahead with our next speaker, Dr. Suresh Damodharan from Coimbatore. He is a very well-known endocrinologist from Coimbatore. He will be speaking on Empagliflozin plus Linagliptin, the fixed drug combination that ticks all the right boxes in the metabolic syndrome. Over to Dr. Suresh Damodharan.
Good evening, everyone, and thanks for the wonderful opportunity. And it's fantastic to see a crowd of this thing in the evening, probably almost the last talks of the day. So possibly next 15-20 minutes or so, if I can take your time in just explaining how the combination therapy that works, which has been in the market for a while, but I think it is very important to understand the science either with the molecules on its own or with the combination. So Empagliflozin, Linagliptin, the reality is these molecules have got the evidences which is abundant, and the FDC, it makes sense to have an FDC which ticks the right boxes in metabolic syndrome. So we know the Indian scenario for diabetics, the whole conference in 2 days, you must have heard plenty of times, but I think it's a huge challenge among the Indian patients. And subclinical CVD and CKDs association is the biggest challenge. And when we are with the Boehringer, we used to have a trial to find out about the subclinical CVDs instances. So heart and kidneys interact through multiple pathological ways. So it does act in a multiple pathology, and that cartoon tells you how complex it is with the cardiac features, the imaging modalities. What are the imaging modalities available? The CTs and ultrasound and nuclear medicine. So we get the dobutamine and other scans just to check for the vascularity and the functionality of the heart. So holistic patient-centered approach is the way forward. In a diabetes, which is a multicentric pathology, we really need to approach everything together rather than just approaching probably glucose-centric way, if you know what I'm saying. So a neurohormonal dysfunction, EGFR decline, albuminuria, the microvascular this thing, and atherosclerotic with the macrovascular involvement, and insulin resistant and beta cell dysfunction. So it has to address the whole lot. Then we got a molecule which can address it, and then therefore it will give a benefit to the patient. So the priority is number one, the patient has to see a benefit of the good glycemic control, and we also need a good glycemia just to get the maximum benefit according to Wikipedia's data. And CV safety is primary important, and the renal impairment safety is also important. So the prevention of the comorbidities, which is the micro and macrovascular disease, gets a priority. So these are the top priorities that we should address. So let's see the rapid effect. So EMPA is a drug which has been hugely studied, and when the EMPA-Reg came in, and we are all surprised by the immediate takeoff of the curve with the cardiovascular benefit. So if you look at the fasting plasma, as I said, the priorities wise, the glucose control. So you see the C-peptide response, beta cell dysfunction, and beta cell glucose sensitivity. Dr. Krishna Seshadri went through with the pioglitazone, explaining how complex is the beta cell sensitivity just for assessing. So on the day 2 and day 14, you see a super improvement with Empagliflozin. So how about the long-term safety? With Linagliptin. So I've shown you two molecules. So the Linagliptin, as initially when it came, it's marketed as a renal safe drug, if you know what I'm saying. So as a monotherapy or a combination with other glucose agents in 2021 patients, 2021 patients, so with the type 2 diabetes, almost like a 2 years exposure with the 24 phase 3 trials followed by 78 weeks open label extension. So the duration is 102 weeks, as I explained, but the focus of analysis is well what the observed case that the total duration is 102 with the previous first week of 24. So you can see in the graph the efficacy of Linagliptin is got no question. It has got a proper efficacious drug. So I spoke about the good glycemic control. Now the second tick box will be priority. So cardiovascular safety, whether it is safe in the cardiovascular wise, as I mentioned earlier, the Empagliflozin clearly showed that there is a takeoff in the initial phase itself, almost 38% relative risk reduction, and in Asian patient is 56% risk reduction. So that boils down to 21% risk of less risk of myocardial events with empagliflozin with placebo. So that is an amazing science that evolved at that time. We all changed our practice, and the SGLT2 came into market in a big way. But EMPA, when it showed the curve change immediately and the cardiovascular benefit immediately, it is really made us to use these drugs in a big way. And now cardiologists are saying it's a cardiology drug with SGLT2 inhibitor. So 3P MACE, myocardial infarction and coronary vasculation all has got a benefit with almost 22%, 21 and 20% respectively. And the p-value is quite significant. Now if you look at the EMPA as a molecule, it demonstrated low risk of ES, end-stage kidney disease, CV death or heart failure. So that is very clearly mentioned, and you can see the graph showing that exactly, with the green being the GLP-1 and EMPA being in the dark side. So EMPA almost reduces the risk for CV death or heart failure hospitalization. That we all know SGLT2, how the mechanism that acts on, acts like a diuretic, and it does reduces the hospitalization. Previously, for heart failure, we didn't have many drugs. The patient comes in, we just give a diuretic and wait for the response. Now, with valsartan sacubitril combination, along with SGLT2 inhibitors, we got super duper molecule that prevents the hospital repeated. When we are all getting graduated at that time, when we get a admission with a heart failure, the patients will repeatedly be coming. But now, with the invention of all these drugs, it made a huge difference, especially with heart failure, hospitalization and CV death. So how about Linagliptin? It is with the Carmelina trial. So these drugs are really well studied. Carmelina showed that hospitalization for heart failure, the DPP4 has shown some signal for heart failure, but that is not the case with Linagliptin. And as I say, the Saver-TB TCOS examined with allogliptin, that is when we, in ADA Canada, long back in 2007, if I can remember, yeah. So, and then Carmelina has showed clearly that signal was not present with the Linagliptin. And it has got a proven reassuring cardiovascular safety profile, again in Carmelina, showing compared to Saver-TB with saxagliptin and examined with allogliptin and TCOS with sitagliptin, Carmelina proved to be clearly winning the race in 3P MACE and heart failure. So that makes me to come for the third point of the priority. So I've touched base on the 2 points already, but the renal impairment safety is very important thing. And Empagliflozin showing that the incident of worsening nephropathy is almost 39% risk reduction. So that is the Empagliflozin outcome. Protection with the SGLT2 inhibition is beyond doubt in the patients with type 2 and CVD. And macroalbuminuria and doubling of creatinine, that all comes down to 46% risk reduction. We didn't have any kind of these molecules before, and these molecules have made a huge difference in management of diabetes and its related complication. As I mentioned, the priorities, what I showed you. So EMPA facilitates the regression of albuminuria, and we do have patients come in with early stage. We are all getting more sort of academically educated, and when we go up to clinical practice, we check the albumin level and everything, and albuminuria, when it goes up, the EMPA can be used as a molecule which will reduce, which is the Empagliflozin outcome trial. Patient with prior microalbuminuria, patient with prior albuminuria, progressing to the next level is reduced when you start using the Empagliflozin. Almost 43% with EMPA and 82% likelihood with EMPA. So consistently it improves the kidney outcomes. With the EMPA kidney trial was so reassuring to show us that the kidney disease progression to CKD, diabetic nephropathy, kidney failure in type 2, with CKD, showing 45% and 44 and 41% risk reduction respectively. So across the baseline EGFR levels in people with type 2, clearly the odds ratios rapid decline and clearly indicates a renal benefit. So EMPA use may potentially delay by up to 27 years and avoid dialysis. So when you want to convert that into health economics, it is mind-blowing statistics that we got with this kind of drugs. So molecules as tablets, as I mentioned, heart failure, those days nothing was available. And now with all these modern drugs, we can potentially change the equation along with probably the mineralocorticoid receptor antagonist, MRAs. We're talking about sacubitril valsartan combination, SGLT2 inhibition. So all these three, if you tend to use for inpatient and outpatient heart failure patients, it definitely reduces this thing. And EMPA kidney has proved to be super duper advantage with the kidney thing. So Linagliptin, as I said, initially it's marketed with the renal safety, which is beyond any gliptin that has been studied, and with the practical experience as well. Since it's marketed for kidneys, we had a real world evidence as well more with Linagliptin. So no dose adjustment is needed. The 5 milligram can be used, and the rest of the other things needs definitely a dose adjustment. So it is conclusively proven for a long-term safety with Camelina. I've showed you with the cardiac safety, but kidney safety is also there with albuminuria progression reduction. So the efficacy of Linagliptin remains this thing in a normal kidney, mild kidney, moderate kidney, and severe kidney disease. So we can pretty much use until you refer to a nephrologist, and even after referring to nephrologist, they will be continuing that most likely. So even with end-stage renal disease, you can continue. So how I've spoke about these molecules separately, but I think EMPA and Linagliptin combination can be a good fit, and it is an FDA-approved drug with Boehringer was marketing in initial stages. Only SGLT2 and DPP4 combination had got a FDA approved. So it makes sense with the DPP4 inhibition, with all this thing. I'm not going to read out, but you know very well about that. And then SGLT2 has got its own unique advantage with dysfunctional adiposity and the heart failure outcomes when we've spoken about for last 15 minutes or so. So combination study showed over 52 weeks the benefit is super duper significant, and the efficacy wise A1C reduction is really good with the body weight efficacy. There is a good reduction of the body weight. When you want to combine all these two molecules, there is a CKD prevention and management. You can see the risk assessment, the CKD associated with high mortality. We know that renal failures patient, they don't die of a primary complication of kidneys, they die of heart disease most likely. And then heart failure increases, we spoke about, and end-stage kidney disease, hypertension, arrhythmia, and hypoglycemia. Of course, that can happen. So we need to do the BP control, glucose and lipid albuminuria. But in addition to that, if we put all these patients on the right medication, we're really going to win this race. But management-wise, you have to screen, as I mentioned, urine ACR and then EGFR, which can be done, and CKD with the diabetes and CKD without diabetes. As I mentioned earlier, the two SGLT2 and non-steroidal MRA with finerenone and GLP-1, you must have heard in other lectures for past 2 days. So this is almost my end slide. We're coming to ADA 2025. Clearly, any guidelines for that matter, it makes sense to use the combination drugs with each molecule has got its unique benefit, and you can see in between the SGLT2 has been showed with the arrow. It's got a primary reduction in the kidney disease, primary reduction in the heart disease. So that makes it a unique molecule. So I just conclude by saying diabetes is a dynamic disease, and we're all working for improving quality of life. And really, these two molecules are studied extensively, and it makes sense. And this is a FDA-approved drug with EMPA and Lina showing very much efficacious and got kidney benefit, heart benefit with properly conducted RCTs. And this is, as I said, the only FDA-approved drug. So thank you very much for listening. And hopefully I finished on time. Thank you.
Thank you for the excellent deliberation of the fixed combination of EMPA and Lina.
Thank you, madam.
We can take up 1 or 2 questions.
Yes, ma'am.
One thing is that I think, of course, there's a risk of genital infections
Yes,
with
sir.
the use of EMPA, which is less when you use this combination.
Combination, okay.
Because the DPP4 attacks the bacteria, and the better control of glucose also. Is there any cardiovascular benefit study with Linagliptin?
Yes, sir. I showed you.
Linagliptin, what is the...
I showed you, Kamalina.
No, that is non-inferior. Non-inferior.
Superior.
It's a non-inferior study.
Yes, sir.
That's all.
Yes, sir.
Not
So,
anything in particular. Nothing like EMPA.
Yes, sir. Now, coming back to your first thing, what you asked for the combination thing, anybody has got experience in finding out that genital infections are less when you use gliptins along with it? Krishna, sir? The question is, I think practically, do you find using SGLT2 separately and using with gliptin as a molecule combination, the genital infection is...
There are published studies already. There are RWEs also that show lower incidence of infections with the combination. Yes.
Yes.
So when metformin, till what stage you can use metformin? GFR, EGFR?
Well,
Because
I think
some even with nephropathy, many are using
Yes, sir.
metformin. Yeah, that's why.
yeah, well, so, I think it's very interesting. There's a lot of clinicians
Because
will
once
be...
the creatinine is going up, many people, even if it goes above, many people tend to stop metformin.
Yeah.
So,
It is-
but nowadays, nephrologists even to above 2.5
Yeah.
and all, they are all using it. And
Because the problem is when you do stop metformin, the control goes out, which will in turn damages the macrovascular disease progression and other things. It will be pretty bad when the control goes off. So when you do stop metformin, you'll be seeing the insulin usage will go up phenomenally, but the weight gain happens, the kidney gets more strained, fluid retention happens, and it is not, it's no brainer. Sometimes it's better to continue, but I think the levels, lot of clinicians tend to use it until age of 30, 45 to 30. But
And also Fendrinone, you have to use the starting, you have to go for the highest dose, or you can slow.
which one is, sorry?
Fendrinone, ventrilocorticoid antidote.
Yeah.
Okay, so we can start with, for a normal nephropathy patients, whether we can start with 10 to 20 or you have to directly go for 20?
No, you can start with 10 because the tolerance has to be accepted for any patient. So rather than just going to high dose first.
Okay.
Thank you. Thanks.
Okay, if no more questions, we'll wind up the session.
Thank you.
Okay, thank you, sir.